So I'm Ryan, not Phil, but that feels like a pretty good life goal to me. Um, so what I'm going to talk about today is really a collaborative effort between the California Department of Public Health Office of AIDS, STD Control Branch, the people who really manage and run our surveillance system, and many of our local health jurisdictions about adapting some of our systems to support integrated field investigations. And just as a quick aside, a number of people have worked on this and could easily be up here for chatting about it. So I'm kind of a placeholder for a collective group of people who've been working on this. Going to do a little background and then talk about the two projects, one of which is called the STD HIV Field Investigation Incident, or SHIFI, and the other is Local Interventional Surveillance Access, or LISA. So just a little bit of background. When a health department receives a newly reported case of HIV or STD, there's a number of public health actions that could be taken to kind of help support getting that person the services they need. So I've listed a bunch here, but what I think I would say is there is strong evidence that we need to be thinking about this service delivery holistically and what the client needs, both from a HIV, STD, hepatitis C, and many other services perspective. We know from our STD surveillance data, we currently estimate about half, a little over, of our MSM would benefit from some sort of HIV prevention or care intervention for newly reported syphilis cases. And we also know the inverse is true, that there's profound disparities in new syphilis diagnoses among people in HIV care. So the next slide that I want to talk about, I'm calling the prior approach. And why I have this slide here is historically, the way our systems have been set up is that if clients were getting services for HIV, the people doing that work had to put that information into one system. If it was more driven by STD initially, there was a different system. And sometimes, depending on who the funder was, that system could change as well. And so you can imagine, this is just an example of a few different interventions, but there's 3 different databases where basically the same information is going into. And so you can imagine that this presents a structural barrier to integrated service delivery for a lot of our health jurisdictions. And we see that around the state. We have quite a bit of variation. So we have some counties where there's a very definitive HIV side of the house and a very definitive STD side of the house. And these systems are really, really challenging to overcome. And you'll have a client who maybe needs an integrated service, and there's multiple people reaching out to that client simultaneously. And I think we can all agree that's not the most client-centered approach, nor the best use of public health resources. Then we have some counties that those barriers are still there, but they're pretty clever and have found workarounds to kind of help coordinate the outreach efforts. But the challenges of these multiple systems still exist. And then we have some counties that have really been able to integrate that follow-up within a single person who can reach out to the client and provide that more holistic, at least in terms of HIV and STD follow-up. And so the goal of the 2 projects I'm going to talk about is really to support that third level. So the first one is the STD HIV Field Investigation Incident, or SHIFI. And what it is, it's a recently developed incident or record within CalReady, which is the statewide surveillance system for communicable disease, that'll be used to document health department follow-up work for reported cases of STD and HIV. Just a screenshot of the tabs, but the way it works is investigators are in there and then they kind of move through these sections as they're doing their work and can document the work. And the SHIFI really consists of 6 sections. So there's a patient section, demographics, locating information on where to find the client, and as much as possible, information from surveillance will be piped into that to try to minimize duplicate data entry. There's a section for tracking the investigation. So who is it assigned to? How many outreach attempts? They've made 3 phone calls, 2 field visits, any of that type of information. A section to document linkage to care. And when I say linkage to care, I mean linkage to care, not linkage to one type of care. So in there, there's HIV care, linkage to STD care, HCV, PrEP, other services, so that if people are reaching out to the client, all of that information is there for them to be able to document the work that they do. Then there's a section for client risk information. Information you gather from the client, maybe historically on something like a syphilis interview record. And then lastly, there's a section for contacts. So when following up with a contact, if you elicit a sexual or cluster contact, there's a mechanism to record that information and then create one of these SHIFEs to document all the follow-up work with the contact. And then the last section is just a part of our system that essentially allows for transfer of cases between jurisdictions participating in CalReady. So you could be in one county and say, oh, we found out this person is elsewhere, and then transfer it or move it to another county so that they can pick up with that record. I don't think we need to go into this too much, but the main point is it's a little different, I think, than sometimes how some of us are used to thinking about the data. So the two incidents, this is just an example of a client who's co-infected with syphilis and HIV. So the two records to the left would be the surveillance records. So a lab report comes in that triggers a surveillance record for HIV, maybe another one for syphilis. So those get documented in the system. And then if a health department wants to follow up on that client, they would create one SHIFE. So one record, and they say this record applies to this syphilis case and this HIV case at the same time, and can document that follow-up work simultaneously. So the goal really was to minimize people having to enter data twice or in two different systems. Everything to the right, I don't think we need to go into. It's just to show that there's a mechanism in there to do that same work for any sexual contacts that might be elicited from the follow-up of that case. And I think maybe we'll skip this one a little too, but all to say it's kind of, we've been going through a fairly systematic development process. And right now we're doing some of our final checks for business rules and things within the system to make sure it's gonna work the way that we're hoping it will. So now I'm gonna pivot gears and talk about the LISA, or Local Interventional Surveillance Access Project. That's really headed up by some of our colleagues in the Office of AIDS. And what LISA is what we consider it to be, is a nimble solution for two-way local state data exchange. So I think we've heard a number of times, there's post-its, and a lot of people have talked about some of the challenges is timely access to data. And so that is the role that LISA is trying to fill here. And it's really a way to disseminate both client level, but also health department level that's actionable in a timely fashion. And so it's really designed to overcome some of these technical or statutory barriers that have hindered data sharing in the past. And what we're able to do is create routine reports or tasks out of the system to serve that data to our county partners. So just one example, this would be something like a dashboard. So information could be pulled out, it could be surveillance information, it could be disease investigation information, but then goes into LISA, and it could be a dashboard of how many investigations a given investigator has worked, or what the surveillance data looks like year to date in that region, or any set number of pieces of information. And then the other side, it could also be client level data. So all of this is developed to be secure behind all of the appropriate firewalls, so that a challenge we currently have right now, particularly for STDs, but it's going to apply broadly, is that investigators have a lot of technical barriers seeing all the cases they're trying to work. So you can imagine if we have an investigator with 30 incidents assigned to them, and that may be generous saying 30, or is in a lot of cases, keeping track of who do I want to reach out to today, what's my priority, can be very challenging. The days of like paper stacks and the challenges of trying to say, oh, these are my male cases, these are my female cases. This is a solution where that would be able to go into LISA, and an investigator could go in, see their workload, maybe filter it by pregnancy status or by any number of factors to more timely be able to decide what they want to work on. So this one I will talk a little bit about because I think it's key to how it functions. So if you look on this proposed flow, the blue kind of cylinder things at the top are data systems that are kind of up there at the state level. And the way works is kind of the row below those orange boxes would essentially be a routine process or data pull from those systems that gets massaged or calculations are performed or whatever data manipulation cleaning is necessary. So every night data would come out of the systems, the cleaning, massaging, whatever needs to happen happens, and then it would go into that green kind of cylinder, which is just a back-end warehouse. So more or less, information's pulled from all these various systems, calculations, whatever's done to it, and then it goes to a warehouse. And then Lisa, which is the square, is really just the mechanism that retrieves all that information. And then local jurisdictions can go in, look at their accounts, and then see all of that information visualized. So the goal is that this would be kind of a nightly poll, and so that data could be available to our county partners, not real time, but as in close to real time as we think we're able to get. And then the goal is that that information that Lisa displays for all of our partners is actionable for disease control purposes. So just lastly, kind of following or concluding here, I think the big thing I want to point out for Lisa is that there's a local health jurisdiction advisory group. And from my perspective, we could talk to Dr. Will Wheeler, who really heads this initiative. Lisa can be thought of right now as a very malleable piece of clay, where there's a lot of opportunity to shape what type of information gets pulled, what gets served to the counties, and a lot of room for discussion on what is going to be most useful for the work that you all are doing. So there's a local health jurisdiction advisory group, and I would just encourage anybody who, at our county health departments, who really wants to provide that feedback on, it would be really great if every night I could go into a system and see this about X in my jurisdiction. I would advise you to reach out and ask to be a part of that, because I do think there is a very unique opportunity right now to build something that can be as useful for as many folks as possible. So with that, I will say thank you, and just some of the many people who are working on these projects and initiatives.